Hello, everyone. The next topic is about new drugs in sarcoma. The first speaker is Dr. Broto. The topic is there any evidence to use immunotherapy in sarcomas? Thank you, Doctor.
So thank you very much. Thank you. So we will go, this is my disclosure, with this agenda through these points. Firstly, sarcoma immune microenvironment is clearly different than other tumors which are paradigmatic sensitive tumors to immunomodulation, as is in the case of melanoma. The median of mutational burden in the case of sarcoma is 2 mutations per DNA megabase compared to the melanoma, which are 14 mutations per DNA megabase. And similarly, in the infiltration of CD8 positive cells are clearly inferior in the case of sarcoma. Sorry. If I can have some water, I will be very thankful. And also for other potentially biomarkers of the PD-L1 in positivity. So even in general picture in sarcoma is this previous table. We know that there are heterogeneity and there are differences between subtypes, being the higher probability of response according to the microenvironment to PD-1 or PD-L1 modulation in angiosarcoma, UPS, or leiomyosarcoma, because they have higher number of mutations, and lower numbers in myxofibrosarcoma or liposarcoma or synovial sarcoma with less than 2 mutations per DNA megabase. But even in the one specific subtype, which is an example is angiosarcoma, you can find that a percentage of angiosarcoma, maybe 13% of them, have more than 20 mutations per DNA megabase, which is clearly interesting to know for anti-PD-1 or PD-L1 modulation. The TILs in sarcoma microenvironment have been related with a better prognosis in some series, but it's not very clear. And it seems that the best predictive biomarker in sarcoma is TLS, the tertiary lymphoid structures detected by pathologists, means a higher probability to response to PD-1, PD-L1 compounds. So the expression of PD-L1 in sarcoma context is widely varying across different series, so this is difficult to establish any conclusion. And I would say this is not very robust information so far. And but on the contrary, B cells can be more important, and actually they are within these tertiary lymphoid structures. So this could be interesting. And actually, 1 decade ago, this was already published, the value of B cells in the prognostic of soft tissue sarcoma. Petit-Pré published this interesting translational research and indicating that there was 5 different microenvironments in sarcoma. Inflamed sarcoma, which is 15% of cases, and cold microenvironment for which vascular or endothelial expression was higher. And in between these two populations, there were intermediate patients or tumors showing this spectrum from inflamed to cold microenvironment. And interestingly, as I mentioned before, these 3 components, CD8, T cells, follicular dendritic cells, and B cells, are the important components of TLS. And this kind of structures is detected up to in 20% of sarcomas, and this is clearly a predictive factor for PD-1 or PD-L1 treatments. So look, moving on to the treatments with PD-1, PD-L1 components in sarcoma, we have these examples. This was a randomized phase 2 trial, non-comparative, between nivolumab and nivolumab plus ipilimumab. And Sandra D'Angelo found that there was a better clinical outcome in the combination. And by indirect comparison is what we have found as well when we combine anti-angiogenic plus anti-PD-1. Seems that the results are higher for the combinations than just for anti-angiogenic or just for anti-PD-1. But again, this is very difficult to withdraw robust conclusion because the series are different. Some series includes a substantial percentage of alveolar soft sarcoma that has a more indolent behavior, so it's not easy to compare between them. But in general, as you can see here, the combination seems to concede more activity in terms of overall response rate and also in terms of median of progression-free survival. The rationale behind the combination of anti-angiogenic plus anti-PD-1 is that neoangiogenesis prevent the adaptive immune response. So blocking the neoangiogenesis is, in other words, facilitating the work of the activation of adaptive immunomodulation. And so these are two examples of two phase 2 trials. One is the combination of axitinib, pembrolizumab led by Jonathan Tim, with a substantial median of progression-free survival in this series, and our experiences with sunitinib plus nivolumab in selected subtype of sarcoma with median of progression-free survival almost 6 months, which seems to be clearly superior than the median of progression-free survival achieved by nivolumab alone. So, and in terms of overall survival is the same. It seems that maybe it's adding value, the combination. Pembrolizumab has been tested in different scenarios in sarcoma with combination with metronomic cyclophosphamide or other compounds, but it seems it's not clearly superior in these combinations regarding the study conducted by SARC with pembrolizumab alone. So if we compare toxicities, we can see that nivolumab, ipilimumab is related with higher anemia, and nivolumab sunitinib is correlated with higher neutropenia, and pembrolizumab axitinib is related with higher mucositis. Some examples of some specific subtypes where the immunotherapy with anti-PD-1 or anti-PD-1 is working in sarcoma. Alveolar soft sarcoma is clearly one example because in this tumor in the right thigh, we achieve almost a complete response, a complete radiological response that in the end there was a pathological complete response in this case after the resection. And in this other case, we can see some Rethis response and also some Choi responses. So it's clearly active, and we are waiting for the publication of a collection of alveolar soft sarcoma treated with anti-PD-1 compounds that have been conducted by Nadia and is already accepted in ESMO Open, and also emphasizing the message that anti-PD-1 compounds are active in this disease. This is another example of the differentiated chondrosarcoma with a good response after the combination of sunitinib, nivolumab within the IMMUNOSARC trial, and the same with clear cell sarcoma or angiosarcoma with this bulky disease in the axilla with a very good response after this combination. And actually, we have presented recently by Dr. Hindi in ESMO and CITOS meetings the vascular cohort within IMMUNOSARC where angiosarcoma patients can have overall response rate of 27% with the combination of sunitinib plus nivolumab. So again, a subset of sarcoma subtypes can be benefited with this approach. But we have very surprised with the experience of the chemoimmunotherapy in the first line of leiomyosarcoma. This was presented by our team in the ASCO meeting. So targeting the concept of immunogenic cell death. This is a peculiar type of cell death induced by some drugs, and doxorubicin or anthracyclines are one of the key drugs able to induce this kind of cell death. And then with this strategy, with a regimen that contains doxorubicin and combined in this case with dacarbazine and nivolumab, we can act in two parts of the ICD circuit. So this is the rationale behind this combination, and it's true that a previous combination of doxorubicin plus pembrolizumab in advanced soft tissue sarcoma seems to be more active than doxorubicin alone in direct comparison. But for our surprise, this combination was extremely active in leiomyosarcoma patients in the first line. So we are now preparing the manuscript, and we are now reviewing the images, but we will go to 65% or around that of overall response rate in this specific population. So interestingly as well is that within the 6 first cycles, because the scheme was 6 cycles of dacarbazine plus nivolumab, and then after nivolumab in the maintenance phase for 1 year, but during the combination, no patients, with the exception of one, progress. This patient that progressed during this 6 first cycle progressed up to 24% of increase in RECIST evaluation, but the investigators said, I have noticed a clinical benefit in this case. Please, we should continue with the treatment despite this RECIST progression. We allow that with a waiver, and the patient was stable across all the remaining cycles, and it actually was stable for 8 or 9 additional months. So it's very, very striking observation that during a combination phase, you will not find any patients with progression. This is the first time in 30 years of oncologists devoted to sarcoma. So it's very, very interesting, and the overall response rate is the double that it has been published with the combination of dacarbazine plus doxorubicin, which is 30% in the retrospective series, because this is the first prospective study combining these two compounds. And interestingly, not only we have seen responses in the bulky masses, but only in the tiny nodules in the lung, the response was very deep, which was also very notorious finding with this combination. Obviously, the cellular therapy, I cannot have aboard that with the limited time, but as you know, TCR T-cell therapy has been another kind of immunomodulation that has been attempted in clinical trials, but the patients here were heavily pretreated with several lines before the TCR T-cell therapy, and we have detected activity in this kind of treatments, but no robust conclusions around the recommendations of this therapy can be done currently, but it's for sure very promising approach. So very quick promising or hopes. We have detected in the chemoimmunotherapy trial, and this is a work in charge of David Moura, that one of the canonical biomarkers or immunogenic cell death, which is HMGB1, was increased over time in blood after this combination. That means that we have activated this kind of cell death. And more interestingly, this increase higher than this cutoff indicated that these patients will have a longer progression-free survival. So there was also a correlative or correlation with prognosis, which is very, very interesting. Obviously, there are other immune checkpoints that can be explored in sarcomas and in other tumors. There are these examples, and also different cell effectors and macrophages can be important as well in the tumor microenvironment in sarcoma. Actually, macrophages represent 50% of the sarcoma mass, which is very, very important. And in this regard, we know that we have drugs that are able to inhibit CSF1, which is a very powerful signaling pathway that modulates macrophages. And in this sense, we have designed a clinical trial with the combination of gemcitabine docetaxel, because they are modulators of macrophages, with anti-CSF1. This study will be activated in the upcoming months. So there are new strategies, there are new knowledge stemming from correlative studies using this kind of compounds, this anti-PD-1. This is the case of our study. And currently, the technology for multiplexed allows us a better and a deeper study in microenvironment, in that the cellularity, the density of different cellularities can be measured and can be correlated with the results, which is very, very interesting. And also the matrix, the extracellular matrix, is important. So my remarks are here. PD-1, PD-L1 axis is less relevant in sarcoma than other paradigmatic immunomodulating tumors. This is true. But it's also true that there are some subset of sarcoma that can be benefited beyond any doubt with this kind of approach. And the chemoimmunotherapy seems to be very, very promising approach, especially when we are studying histology by histology. And the same experience we have had in glioma and sarcoma is replicable with UPS. It's still not presented, but our experience is very good. So cell therapy is promising, but maybe this modality should be tested in earlier phases, and we don't have enough information to recommend. So thank you very much for your attention.
Thank you, Dr. Javier. Any question for the doctor? Okay, the next presentation is a video. It is of Dr. Salvatore Provenzano. Salvatore is a medical oncologist working at the Istituto Nazionale dei Tumori of Milan in Italy, and he is completely dedicated to sarcoma patients. He has particular expertise in sarcomas of the young adult and collaborates in several clinical and translational trials to develop new drugs and new strategies for sarcoma patients, and is a very friend of us. Please, the presentation of Salvatore.
Good morning, everyone, and thank Matias, Tomas, everyone there in Argentina for the invitation to speak at this wonderful Congress. Unfortunately, I couldn't join in person due to personal reason, and so I lost my chance to visit the World Cup we've not been seeing in Italy for long. Today I have the role of talking about targeted therapies in sarcoma, a piece of science or a real help for patients. So you all know the biggest evidence regarding targeted therapies in sarcomas is all around selected histotypes. Chemotherapy is still the best for the majority of sarcomas. Cysts are becoming more complex in the treatment day by day, much like liquid non-small cell lung cancer when oncogene driven. We can target KIT, VEGF-alpha, BRAF, and TRAC, MET, by imatinib, sunitinib, regorafenib, ripretinib, avapritinib, cabozantinib. We've been also studying the different effect of certain drugs. For instance, ripretinib in selected subtypes, for instance, in secondary KIT mutation after exposure to imatinib. We have PDGF-beta in the dermatofibrosarcoma protuberans, CSF1 in TGCT, ALK and TRAC in inflammatory myofibroblastic tumors. We can use crizotinib, entrectinib, larotrectinib. We have desmoids, which have been targeted, recently targeted by Notch. SMARCB1 deletions as regard epithelial sarcomas, mTOR pathway as regard pecomas, and so sirolimus, everolimus, nab-sirolimus, and so on. The whole family of NTRK-related tumors, and the CDK4/6 and MDM2 drugs, targeted drugs as regard well-differentiated and differentiated liposarcomas. I thought for this presentation we may focus on some anecdotal experiences, quite recent, which may help us in focusing the reality of these problems. And we may start from TGCT, so tenoidal giant cell tumor. It's a benign tumor involving the joint synovia, the bursum, the tendon seat. It's quite rare, and it's caused by a chronotranslocation in few cancer cells, resulting in the hyperexpression of CSF1, which result in autocrine and paracrine stimulation of surrounding cells, and so in the recall of macrophages and monocytes, which in the end represent the majority of the tumor masses. It's not as benign a deadly disease, but no doubt this disease has a huge impact on the quality of life, because it can cause heart symptoms like pain, stiffness, swelling, bleeding, osteoarthritis. It's limiting functionality. And after surgery, there's a high rate of recurrence, meaning severe long-term morbidity, repeated post-operation, and so post-operative complications. And of course, patients may refuse further intervention or bigger surgeries like amputations. We recently tested CSF1 inhibitors. The first one was pexidartinib. It was tested in a randomized placebo-controlled phase 3 trial, in which the versus placebo, and you see the results were quite impressive. Response rate at week 25 was 56%, increased to 67% after the 25th week. And no doubt, any patient would be happy of achieving such a response. This is a hand of a patient or one of our patients under pexidartinib instead of receiving an amputation. The problem was safety. So, because even if the majority of the patient had grade 1 to side effects, we saw some severe cases of liver toxicity, which most of the times occurred in the first 2 months of treatment, like ALT, AST elevation, usually reversible, but some harder cases of mixed cholestatic hepatotoxicity, some cases fatal. And so, of course, the problem was balancing the potential benefit of this drug in a benign disease with the risk of being fatal. And this is why the drug was approved by FDA, not from EMA in Europe. Better results are much likely awaited with wincertinib. The initial results were presented in a poster at the recent CTOS last week, in which no serious adverse events were seen in 46 patients. As regards desmoid, one of the breaking news of this year, desmoids are, again, rare, locally aggressive and invasive tumor, never metastasizing, and with the possibility of individualizing, personalizing the treatment in order to improve the tumor control, to improve symptoms. And don't forget, in rare cases, this tumor may also be fatal. For instance, those arising from the mesenterium due to bowel occlusion and some bleeding, some other complications. We know from the biology that this tumor usually express high levels of Notch. We have drugs interfering with Notch pathway, especially gamma secretase inhibitors, and that's why we conducted a phase 3 trial versus placebo with using nirogacestat, the first generation gamma secretase inhibitor. The results, again, were quite impressive, with nearly all the patients achieving all the kind of response, and all these patients were progressing before starting the treatment. You can see that, because we know from the natural history of this disease that even some patients responded to placebo. However, there's no comparison, and the huge difference in progression-free survival. Again, some side effects, usually very well manageable, not problematic, with some initial alerts regarding ovarian dysfunction, which seems to be reversible, and so not really a problem. You can see here an example of a long-lasting response, and this drug, much likely, is gonna become practice-changing, because you know that from the global consensus, the initial frontline approach for this disease may be active surveillance for 1 up to 2 years, and then going on if there's no progression, or if there is, of course, a spontaneous regression, which is, as you can see, quite likely, around 30%. But if you were a patient, would you like to wait for 1-2 years and maybe in the meanwhile seeing the tumor growing, or would you like to start an immediate, very well tolerated treatment in a way to shrink the tumor and solve your symptoms, your problem, and everything else? So again, much likely we will see some changes in the next future. And then the last news we have. For well-differentiated liposarcomas, you know that these drugs are dependent on MDM2 amplifications, because this MDM2 is connected to p53, and so the rationale of using anti-MDM2 drugs were justified from the possibility of helping p53 restoring its levels, and so slowing the tumor growth and preventing progression. The first drug test was milademetan. It was, again, an oral drug. It was tested in second line, again, versus trabectedin. And the results were not really as expected, because you can see that even if sometimes you see quite impressive responses, and we have the impression that these responses are mainly, in general, around the well-differentiated component rather than the high-grade differentiated component, the progression-free survival resulted not different from the one we have from trabectedin, with strange results as regards overall survival, in which, again, you don't see any difference if you look at the summary of the statistics, but which may be explained by the fact that the two curves are crossing once and they are really near one to the other at the median. But indeed, if you look at the details of the curves, there's a certain difference, which is in favor, which seems to be in favor of trabectedin rather than milademetan. And this comes after an initial apparent benefit for milademetan lasting no more than 3 months. Of course, this is a temporary result. The data is not mature, but we may somewhat think what may have happened in this sense and look, for instance, to the treatment-related adverse events. The biggest difference is probably around thrombocytopenia, because you know that this class of drugs, this family of drugs, can cause even severe thrombocytopenia due to the fact that these thrombocytes are a lot dependent from MDM2. And you can see that the difference was 60% versus 24% for trabectedin. In some cases, we have seen that even if this thrombocytopenia is usually reversible, sometimes it is not. And sometimes it seems that the sensibility of further treatments is a little bit higher after these patients are exposed to anti-MDM2 inhibitors, like they develop more thrombocytopenia, for instance, from trabectedin or any other further lines drugs. And of course, this may impact in some way the possibility of receiving further lines. And so in the end, these drugs may be an harm for this patient. So in summary, we've seen an example of a target therapy in a benign disease, which is a real help because it improves symptoms, it improves quality of life, however, with some risks. We will wait for second-generation drugs, possibly reducing these risks. We have another example of a real help in a borderline disease, which is rarely but possibly fatal, like gamma secretase inhibitors in desmoid tumors. And we have the example of anti-MDM2 drugs in well-differentiated DDIF lipos that have not shown any benefit in terms of responses and progression-free survival, which may be a potential harm in terms of reducing overall survival in our patients, since making harder our patients to receive further lines. Of course, we will have to wait again for second-generation drug. You know, there's one in the bright line in trial. And so if we go back to the initial question about the role of targeted therapies in sarcomas, I have no definitive answer, because probably, as always, virtue stands in the middle. And this virtue is probably balancing the benefits we await from any drug in terms of tumor control or symptom control, with the risks we have coming from the natural history of the disease or from the adverse events we are awaiting from a drug. And of course, this balance should always be done considering all the factors around, like big rationales, helping to design good clinical trials, which in the end help us in develop new real-world data, case report, anecdotal evidences we may use to develop new translational research, new biology knowledge, and then new rationale for improving the results we have from these drugs. Of course, all these elements, again, interact with a lot of factors like rarity, heterogeneity, and methodology as regards the design of clinical trials, for instance, or regulation policies, one for all, GDPR, privacy policy, and willingness to pay from the health system or invest from the pharma companies as regard with all data, case report, registration, and approval of the drugs. And all these elements would probably deserve a presentation one by one, but we have no time for that. So I thank you for attention. Goodbye.
Well, the next topic is a simple and complex review for the molecular and future horizons in sarcoma. The speaker is David Moura. He is molecular biologist with more than 8 years dedicated to sarcoma research. He is senior researcher in the group of advanced therapies and biomarkers in sarcoma, and he is dedicated to the preclinical and translational research aiming to identify novel therapeutics, target, and biomarkers in sarcoma. Thank you.
So thank you, first of all, for inviting me here today to show you something or some parts of the work that we are currently doing in Madrid. So the title of my presentation is very complex, and I think I could go for hours explaining everything that we are doing in our lab. So I will focus mostly on 2 projects that we are currently doing and try to finishing that are related to the epigenetics and genetics mechanism that can regulate or can be therapeutic targets in sarcoma. So, as you know, cancer is a process in which normal cells gain the capability to proliferate and to spread to different organs and tissues. These 2 are just 2 features of cancer, and if you go to the cancer hallmarks, you know that there are a lot of other features that are important. These features are relevant for the malignancy of cancer, but it's also important to notice that these features are also the vulnerabilities of cancer. And if we understand the biology, and if we understand the key players in all of this process, it's possible that we can develop an important and an active regimen for cancer, and more precisely in our case for sarcoma. For the purpose of this talk, I'm going to focus on the first part on the non-mutational epigenetic reprogramming. And I'm going to focus in solitary fibrous tumor. Solitary fibrous tumor is a fibroblastic tumor that can appear in almost every single part of the body. It's a rare tumor with an incidence of 1 case per 1 million inhabitants each year. And the most characteristic or the most common subtypes are the former called typical and malignant SFT. Nowadays, in the new WHO classification, the low risk and the high risk SFT. This tumor is characterized by the presence of a specific fusion. It normally affects the NAB2 and the STAT6 genes. And all these fusions maintain the nuclear localization signal, so the fusion is within the nucleus, and the immunostaining of STAT6 is an important molecular marker for the differential diagnosis against other sarcomas. Another important fact is that there is several breakpoints for this fusion. However, there is no reliable data mentioning that if these breakpoints have any impact on prognosis. Concerning the treatment, surgical intervention with adjuvant or without adjuvant radiotherapy is the backbone for localized disease, and in the advancing setting, antiangiogenics is basically the only thing that we have that shows some activity, mostly on the typical and malignant SFT. In the differentiated, it is not active. So it's obvious that we have a clinical need, and attending to this clinical need, one colleague of us, she's Dr. Rayenga from the University of Texas, she is also a patient of SFT, performed a high throughput screen with more than 2,600 compounds using 2 different cell lines. They were not SFT cell lines, they were lung fibroblasts and also a colorectal cancer cell line that were infected to overexpress the NAB2 STAT6 fusion. And using this, assay, they was capable to identify BET proteins as a potential target of SFT, in SFT. And if you know which is BET proteins are epigenetic regulators that are capable to recognize the acetylation of chromatin and build the transcriptional machinery for activate gene expression, or in some cases even repress. It has several mechanisms associated with BET proteins, such as the regulation of DDR damages, the assemble of the enantiosome or super enantiosomes, among other characteristics. And when she found this, she contacted us to try to test in our cell lines, that we have 2 cell lines of SFT and also a PDX model, if we could detect if BET inhibitors were active in these models. We begin our studies using 6 different compounds. They are pan-BET for some cases, meaning that they inhibit BRDF2, 3, and 4, and others are more specific, inhibiting just 1 or 2 of these BET proteins, or in some cases, the bromo domain BD1 or BD2. This is something that, okay. In our experiment in terms of cell viability, we observed that mibebrasiv was the most active among all the inhibitors that we used. And analyzing cell death by flow cytometry, in this case analyzing the populations that are under apoptosis or necrosis, we observed once again that mibebrasiv was capable to kill SFT cell lines, these 2, ENT-SFT and EAC139, more actively, for example, compared with 2 cell lines of leiomyosarcoma, in which you can see here that the activity of this compound is slightly lower, or even increasingly lower. It's important to mention that all the compounds that we used induced cell death in SFT. However, it's important to mention the concentration that we used for mibebrasiv, that was only 15 nanomolar compared with micromolar in all other cell lines, which means that we are capable to detect signals of activity with lower doses with this compound compared to the other ones. But why this compound works in SFT? Well, first of all, we decide to analyze it by protein if we can detect some markers, for example, of apoptosis. Once again, you can see here that is a cleavage of part 1, one typical marker of cell death by apoptosis. But there was also increase in the phosphorylation of histone H2AX, that is a classic canonical marker in the induction of the DNA damage. There was a decrease in the expression of cyclin D1, which means that cells are not proliferating, they are reducing their capability to proliferate, and they are arrested in cell cycle. And of course, to confirm that they were arrested in cell cycle, we also analyzed P21 that was increasing after the treatment with mibebrasiv. It is true that we only found this last observation in one of the cell lines, in the primary cell line that we have, but it's a result that we think it's reliable. So sorry, this is a mistake. So how does BET inhibitors can work in SFT? There are 3 hypotheses. One of them is that the fusion is capable to recruit the stone acetyltransferases, acetylating the residues of the chromatin, stones, for example, to induce the binding of the BET proteins to activate the enantiosome and, of course, the transcription. However, it is also possible that BRD4 is binded together to the fusion, and they both work together in assembling this enantiosome. And then the third option, or the third possibility, it concerns the fact that maybe NAP2-STAT6 is a target of BET proteins activation, meaning that BET proteins are capable to induce the expression of the fusion and is regulating somehow its expression. We are testing all these hypotheses, but the third one, we have already some data. And we observed that after treatment with mibebrasiv and the other compounds, It's true that we use, once again, 15 nanomolar for immunoaggressive and for the others in micromolar. We detect a reduction in the expression of the gene of our fusion, NAP2-STAT6, in both cell lines, except one of the drugs that is in fact the one that did not show any activity in for example, inducing cell death. By protein, in the Western blot, we once again observe a decrease in the levels of the fusion, which means that probably there is a transcriptional regulation of the NAP2-STAT6 fusion dependent on the recruitment of bad proteins. So this is something that we are currently working. However, it's not working. However, the importance of bad proteins maybe are not so specific of SFT. And if we go to the literature, there have been several publications mentioning that BET inhibition is active in some specific subtypes of sarcoma. More precisely, in Ewing sarcoma, clear cell sarcoma, alveolar rhabdomyosarcoma, and myxoid liposarcoma. They all share fusion genes. So this could be very important to notice, and maybe we are analyzing or we are studying a mechanism that can be shared by all the sarcomas with a fusion gene. Besides, there are also some publications that mention that this isn't working, that BET inhibitors are also active in some hematologic malignancies, such, for example, AML, in which 30% of the cases have fusions. So once again, maybe this is not for SFT, this is not for only sarcomas with a fusion gene, but for cancers that have a fusion gene. The second part of my talk, this is not working, or? I'm doing next. Okay, so the next part of my talk, there is another study that we are doing in our lab. As I previously mentioned, cancer hallmarks are several. However, there is another mechanism that is not included, at least directly in this representation, that is the regulation of alternative splicing. Alternative splicing can be involved in each one of these cancer hallmarks, but by itself, maybe in the future, it could be also included as one of the cancer hallmarks. And the alternative splicing is more or less the capability of the cells, or it's the process in which a cell from one pre-mRNA, by taking off some exons, produce different mRNAs, which will be translated in different proteins. This increases the complexity of cancer because all of these proteins could regulate differently the expression of other genes or other pathogenic processes. And in this process, one of the main proteins involved are the serine-arginine enriched splicing factors, which are regulated by some specific kinases, such, for example, the CDC2-like kinases, also CLK. And interesting, in the literature, we found out that there is an inhibitor of CLKs called SM08502, also known by sirtuvivint, that was active in reducing tumor growth in solid tumors, in other solid tumors that are not sarcoma. Besides, and one of interesting parts of this publication is that they also observed that this drug was capable to reduce the activation of the Wnt beta-catenin pathway. That is one pathway that is very important in sarcoma, according to previous experience of our laboratory. So, based on these results, and since we have always a huge interest in identifying new compounds that could inhibit the Wnt beta-catenin pathway, we started in our lab to experiment the activity of sirtuvivint in different cell lines. We used the cell lines of leiomyosarcoma, UPS, synovial sarcoma, and we observed that the the cell viability or the EC50 values that were capable to reduce at least 50% of the cell viability were increasingly lower with this compound compared, for example, with the classic inhibitor of the Wnt pathway, in this case, BRII-724, that in our hands was the most active compound in preclinical models of sarcoma. And this was occurred in almost all the cell lines. In some of the cases, the difference was more than 1,000 times lower the concentration that we need to kill cells. Besides, we also confirmed using a report assay that the transcriptional activity of beta-catenin was reduced. This is just an experiment in one cell line, but it was common to all the cell lines that we tested. While we were analyzing potential mechanisms by which this drug works, for example, we are focusing on DDR regulation, also in the development of DNA-RNA hybrids, we started the in vivo experiment. And we used 4 different models. We used a model of leiomyosarcoma, a model of malignant peripheral nerve sheath tumor, SFT, and also synovial sarcoma. We treated our mice with this compound for 5 days on, 2 days off for 21 days, and we take the experiment until basically the progression occurs. And we observed that in the leiomyosarcoma, this compound did not show any, by itself in monotherapy, any activity in leiomyosarcoma or even in MPNST. But it's true that in SFT and synovial sarcoma, the results were very good, and the compound in monotherapy showed to be active at least in these 2 compounds, in these 2 models, sorry. Moreover, we also performed another experiment in combination with doxorubicin. In this case, the schedule was slightly different. The doxorubicin was inoculated 3 times during the cycle, and once again, the sirtuvivint was 5 days on, 2 days off for 21 days. And we observed that in the synovial sarcoma model, the combination was very, very active, more active than the compound by itself. And in leiomyosarcoma, the combination of doxorubicin with sirtuvivint was also active compared, for example, with doxorubicin or the compound in monotherapy. As you can see here in this model, doxorubicin did not show any signals of activity. It's a very aggressive, and we know from the past that it's very difficult to arrest this model. An important aspect is that we observe also, for the first time, at least in my experiments, a reduction in tumor volume. This occurred, for example, in 1 mouse treated with monotherapy and in 3 mice treated with a combination. This is somehow very, very promising. However, there were some signals of activity, toxicity, that we need to control between doxorubicin and sirtuvivint, and as you can see here, there was a decrease in the weight of the mice during the process. But we could control this toxicity by reducing, for example, the number of administrations of both compounds. So there is already preliminary evidence of the activity of this compound in solid tumors. It is true that this was a phase 1. It was presented in ESMO last year. And based on the results, we are doing, and we hope to open very soon, a new clinical trial of CellNet with this compound in monotherapy at least. So I hope I convince you that we have 2 great promising research lines to follow. One related with an inhibition of BET proteins that could be a target in solitary fibrous tumor and probably in other tumors by regulating the transcription of the fusion genes, and also that alternative splicing could be a targetable mechanism, at least in synovial sarcoma and solitary fibrous tumor. Thank you so much.
Bueno, les pido disculpas, pero en honor al tiempo vamos a tener que cerrar la sesión en este momento, porque tenemos esperando a la gente que viene a las 13 horas. Le pedimos disculpas al doctor Amorín, ya hemos hablado con él, el caso clínico queda para otra oportunidad. Les agradecemos a todos, a los speakers especialmente y a todos los que pudieron concurrir a la sesión. Muchas gracias.